A very good evening, and thank you very much, Lady Chairperson, for the kind introduction. Thank you very much for Dr. Sunil and team for organizing such a fantastic conference and inviting me to give this talk. Well, as you have said earlier, dengue is a big problem for all of us, and it's a bigger problem for us obstetricians when it occurs in pregnancy. And this is where I come from, in this real down south state of, city of Johor Bahru, which is just 2 kilometers north of Singapore. This is the Red Hospital where I work in, and actually this is where my labor room is. And if you look out of the window, you actually can see Singapore. Now, the main problem is dengue has been with us for a while. And the sad thing is mothers are still dying because of dengue. Now, if you look at the distribution as to how dengue has been, this was in 2008. And this is the parameters in which dengue is causing havoc. And if you look in 2020, it has not changed much. Actually, you can see Brazil, India, Malaysia, all of us are still within the same curse of dengue. Now, in Malaysia, fortunately, in the last 1.5 years, the dengue incidence has decreased. And we think this is because many of us are staying at home because of the lockdown and keeping our homes and environment fairly clean. And hence, actually, our dengue rates has been coming down. Now, if you look at the serotypes that are available in, or rather that causes problems in Malaysia, it is actually you can see here, it's the DEN1, DEN2, DEN3, and DEN4. And I think all of them have a fairly equal, except for DEN4, which is not really so predominant. Now, if you look into just what dengue is, basically we know it's caused by the female mosquito, Aegypti and albopictus, and this mosquito only can fly for 400 meters. But despite that, look at the damage that it has done. And it's an incubation period of 4 to 10 days. Mostly we are asymptomatic. And the primary infection gives us only lifelong immunity to this specific serotype. And there's no cross-protective serotype. In fact, if you're protected against one, you actually may have a more enhanced and more bad disease if you get infected with the other serotype. So what are the warning signs of dengue? I mean, these are very standard warning signs. You know, you have lethargy, abdominal pain, vomiting, fluid accumulation. You may present with shortness of breath. And of course, you may have spontaneous bleeding, spontaneous bruising. And of course, your laboratory will show probably an increasing hematocrit with the lowering of the platelets. Now, in severe dengue, of course, it becomes a multi-systemic disease, and it can affect from the CNS right up to the heart. And I'm sure most of us have seen all these manifestations. Now, it's important to know that we need to pick up the warning signs, because dengue can just pass off as a very mild disease. Or if you don't pick up the warning signs, then you'll have a big problem in your hands. And once you have severe dengue, then we are in a lot of trouble. Now, the risk factors for severe dengue is actually if you have a secondary heterotrophic infection. As I told you earlier, if you had a DEN2 infection and then you are infected sometime later by DEN1, then you'll have a severe disease. And studies have postulated that the time interval by which you can have severe disease can be as long as more than 20 years. And infants of dengue immune mothers are also susceptible because they will actually passively get the antibodies from the mother, and then they develop these antibodies, but then subsequently they can be exposed to very severe disease if they are infected by the DEN1 serotype. Now, this is a very important table. So if you look at the cause of illness, you'll find when the febrile, critical, and recovery phases, okay? Now, this is the phase in which most of us will have mild disease, and then we'll have fever, and probably the fever doesn't settle, then we will start to go and see the doctor. The doctor will do the laboratory test, and then they will say, yes, you're infected or not. Then as your fever subsides, strangely, as the fever subsides, that is when you get into difficult part of the disease. Okay, and the critical phase is something where you and I have to be very, very vigilant. We'll go along as we see this. Now, as I told you, this is exactly the same thing, and you must see how the antibodies develop. So knowing this is important because then it will give you how you're going to interpret the result. So if you want to interpret the results, then you must know that the primary infection, the onset of symptoms, the test that is going to be sensitive is not your IgM or your IgG, but your NS1. So as your NS1 begins to come down, then you'll realize that your IgM develops. As your IgM is at the peak, then your IgG starts to develop, and then your IgG will persist. But then if you get reinfected with a different serotype, then again, the NS1 is the one that you're going to look out for. So this is how you need to know. So if you're looking just for IgM and you say, oh, IgM is absent, she's not infected, then you're going to get into trouble. So this again is the diagnostic testing and all these tests that we have. I'm not going to go into the details of this, but it's most important that you must know when to do what tests. If based on the history, the person is in the initial state, then the investigation to do is your NS1. If she's already coming out of the fever, then you may have to do your IgM. So this again is something, if you can remember this, I'm very happy. From your 0 to the first week, you will find that your NS1 is most reliable. Then as your IgM starts to peak, then that is available. You can test it, and then you will have both IgM and IgG available. Then you'll have absence of NS1. So that is when you will know that this person has gone to the acute illness and now going into the critical and probably subsequently ease down into the recovery phase. Okay, so now if you look into dengue and pregnancy outcomes, you can see that the cesarean section deliveries, okay, gives rise to a high amount of maternal mortality, okay, and these are the other associated fetal conditions that I'll touch on a bit later that also coexist with dengue. And many a time we have to resort to deliver the baby because of a deteriorating maternal condition, and we feel that at least we will try to save the baby. But at all times, keep in mind, mother is always the priority. Now, if you look at dengue and fetal outcomes, then you can see that miscarriage, stillbirth, preterm, and low birth weight are still some of our major concerns. Now, in Malaysia, we have had so many guidelines, and guidelines are coming, but despite that, we are losing our mothers. So our guidelines has to be something that is keeping with the current trend and is always keeping in touch with what is happening at the ground level. So when we reviewed maternal deaths due to dengue from our confidential inquiry into maternal deaths, the Malaysian report over 2 reports, that was 2009 to 2011, 2012 to 2014. The next report, which is 2015 to 2017, will be out in a couple of weeks' time. So the timing of death, okay, was mostly in the third trimester. Okay, and the underlying comorbids was none of them actually had a comorbid. They just had this pesky mosquito biting them, and they came in with very bad illness, and we lost them. Now, the duration or timing of stay in the hospital stay was, of course, you will know, if average duration of symptoms, 3 days, 3 of them, and the majority of them had a hospital stay of more than 7 days. That means we actually tried our very best to save them. Now, the red flags during admission, that if you look at the earlier slide where I showed you the warning signs, all our maternal deaths had fever. But what is interesting is almost 50% of them had diarrhea. So this has actually made us become more alert. To say that if a woman comes in with fever, a pregnant woman comes in with fever, complaining of diarrhea, then we will always think of dengue. And now, of course, we think of COVID as well. Okay, red flags clinical signs on admissions, okay? And strangely, you'll see only 50% had a temperature of more than 38, okay? Probably because they had taken some antipyretics or things like that. But the majority of them had tachycardia, all right? And in terms of investigations, the one that actually, if you're looking for leukopenia, in our study sample, we only found that 7% of them had leukopenia, and only 20% had thrombocytopenia. But about 30% of them had actually had leukopenia. So it's good to know that this is some of the parameters that can actually alert us to a mother who is in trouble. So this is the guidelines that we have developed, and you will find that in the febrile phase, this mother just has a viral fever. And then as the fever subsides, many of us have this false sense of security that she's getting better. But what we must realize is as the fever subsides, as she goes into the critical phase, that is when we get into a lot of trouble. Why? That is when the plasma leakage will occur. There will be movement of these fluids. Once there's movement of fluids, then this woman will have hemoconcentration, then she will have platelet consumption, which then is going to make her become more and more susceptible for spontaneous bleeds. Now, if you can manage it in the critical phase appropriately with supportive measures, then she will come into the recovery phase. So basically what we are looking at is monitoring. You see, you must understand there is no magic bullet that we can give for dengue and say, if I give her 2 doses of this for the next 5 days, she's going to recover. No. The only way we can manage dengue well is have a hawk's eye on her, monitor her like a hawk, and then manage her symptomatically and appropriately, and you will tide yourself out of the storm. Now, what we sometimes do, we may even do full blood counts, platelet counts 3 or 4 times a day. We will look at urine output, look at liver function, look at other parameters to make sure that we are not missing out, going into a systemic complication. Now, this is our dengue assessment checklist that we have developed, and this is not only used in pregnancy, this is used across the board, and we find this very, very effective because it's a very easily done. It can even be done by trained nurses. It can be done by even house officers. And all it does is tells us, like in a dashboard, what is happening to the patient and alerts us to what we need to do next. Okay. Now, what are the key points? Okay. What we found was that we suspected dengue only in about 50% of the patients. And of that, more than 75% of them had a platelet count that was healthy. One patient had developed a subrectus hematoma, spontaneous subrectus hematoma. 62 patients had a hematocrit of more than 35%. 80% of patients had no leukopenia. Fetal loss in severe dengue was about 67%. That means we actually lost nearly 70% of the babies. Okay, so now from our limited find, we found that diarrhea is a warning sign. Leukopenia is present, but it is not a very sensitive indicator in pregnancy. And most important thing is when a woman has a fever and she comes in with an abdominal pain, do not think it is labor pain. It could be an abruption. It could be an evolving hematoma. Okay, keep a close watch on the pulse rate and the temperature. Look at your early warning system charts if you have one, and keep an eye on your serum lactate as well. Okay. Now, what is important is we all come from an endemic country. Keep a very high degree of suspicion. Mother is always the priority, and we must know when to do investigations. I told you earlier, when to do the antibodies titer is very important. Be hawk-like and surveil the patient appropriately. Intervention when you think it's appropriate, and a multidisciplinary approach goes without saying. What not to do? Do not make hasty decisions. When I say hasty decisions, the mother will say, save my baby at all times. And then you attempt that, you end up losing both. Do not be overconfident. You may have handled hundreds of dengue cases, but never 2 are the same. And never underestimate the disease. You underestimate the disease, it will leave you with the diseased. No specific treatment, as I told you earlier. Okay. What we need to do is make sure that we have the appropriate supportive therapy. And if you do that, mortality can be reduced to less than 1%. Maintenance of the circulating volume is paramount in management of our dengue mothers. This slide again, I cannot tell you, this is again how the disease progression is. And this again in the critical phase, this is when most of the damage happens. This is where you have to be hawk-like. So if you can get a good chronology of the disease, then you know exactly when to focus your attention on which category of patients, and you know exactly what investigations do in which phase of the disease. Now, this delivery does not solve the problem. If you're doing a cesarean section, always give platelet cover at the induction of anesthesia. Make sure that the senior most competent surgeon goes in with a competent anesthetist, the competent neonatologist. We do not want situations where the surgeon gets into trouble, calls for help. By the time the senior person scrubs in, you end up with more trouble. Okay, so it's very important. Post-operatively, we have to have appropriate monitoring settings. Of course, the baby, we obstetricians will pass the buck to the peds. Now, blood transfusion, if there's significant bleeding, there must be platelets available. If platelets are not available, then you will get into trouble. And then you must make sure that regardless of the severity of thrombocytopenia, you must make sure that you don't simply give platelet transfusion unless it is less than 10,000, because then you have issues with spontaneous bleeding. Okay, anticipate DIVC. That means you keep a close watch on your coagulation profile and make sure you have the appropriate blood products to protect the patient. Avoid IM injections, because many of us are still prone, and if the anesthetist accidentally gives a IM Synto at the delivery of the placenta, you may end up with a huge what you call this hematoma, which will cause problems. Okay, avoid invasive procedures. Do not do internal CTG monitoring. Do not do fetal sampling, because you do not know whether this baby is actually having dengue itself. Yeah. Episiotomies only do if it's necessary. Make sure it's properly sutured. Make sure that you catch your bleeders well. As far as possible, avoid instrumental deliveries. Watch out for hemoconcentration, because if the hemoconcentration goes more than 40, then it becomes very, very worrying. Keep an eye on all the other organs. Yeah, it will easily develop into a multi-systemic disease. Okay. Now, in this study that was done in 2020, we found, when we looked at 40 pregnant women, we found the adverse maternal and fetal outcomes was the mortality rate was almost 16%. That means 16 mothers out of 10 died. Okay, the preterm and postpartum labor hemorrhages were significant, and there was the preterm labor and postpartum hemorrhage was a significant cause of morbidity to both mother and baby. Now, you must always understand there's a risk of vertical transmission to the baby. Okay, it's more frequent when the maternal dengue is towards later part in the pregnancy. That means more in the third trimester. Then there's a higher vertical transmission rate. If dengue during pregnancy or fever within 15 days before term in a dengue anemia, always check the baby for dengue. The result is positive. Keep a close watch on the newborn. Okay. Now, the vertical transmission rate can be as high as almost 23% in a study that was done in 2018. But vertical transmission has been described between 12 to 64%. So again, this depends on the gestational age. The more advanced the gestational age, the greater risk of vertical transmission. Okay, and it's also important to know almost 20% of the babies that were delivered to a dengue mother actually were positive. Okay, now dengue vaccine is something that has been around. There was a bit of a problem when they vaccinated naive patients in Philippines that became a catastrophe. But subsequent to that, WHO recommends that vaccine only be given to persons with confirmed previous dengue virus infection, not to those who have been just suspected to have dengue, because it can cause problems. Yeah. But what are the salient points to know? Ensure availability of blood products. Watch an excess site. Watch your urine output, uterine size. Make sure the next of kin is informed and notify the disease to your public health officers. Always counsel patient and family. It's a team approach. Make sure the appropriate investigations are done. Trace the results, because many times we do investigation, we don't trace the results, and by the time the patient deteriorates, then we trace the results, and then we realize we could have acted on much earlier. Again, fluid therapy is important, and always anticipate problems. And of course, prevention and vector control are very important. So this goes without saying, and I think if we can get rid of the mosquitoes, we can get rid of dengue. Ask yourself, always ask yourself when you're dealing with a patient with dengue, will the patient bleed? Will the fetus bleed? Will I bleed as the obstetrician? Will I be bled and I get sued? With that, thank you very much.
Thank you, Dr. Anju, for the kind words. Next 20 minutes, I shall be discussing about our experience on handling these PART students which came to our center, within our center with cardiac arrest, and we had today perimortem cesarean section. Nil conflict of interest, and the photographs that have been shown or have been obtained with the patient's consent. So as I said, this will be our experience that I shall be sharing, and more or less it is what is mentioned in the literature. To complete the topic on this cardiac arrest, I just start with definition. And maternal mortality is defined as the death of a woman during pregnancy and up to 42 days after delivery, or the termination of pregnancy, provided that the cause of death is related or aggravated by the pregnancy or its management. If you look at the incidence of maternal cardiac arrest, is roughly 1 in 12,000 admissions in the USA, and globally, every 108 seconds, there's approximately every 2 minutes, there's a maternal death. And globally, if you look at the incidence, is 1 in 36,000 and relatively rare event, fortunately. But it's a very challenging scenario because it involves 2 lives or multiple lives. It's a multi-fatal pregnancy, and CPR in pregnancy is uniquely different. Caregivers must have a thorough understanding about the maternal mortality causes, which are a little different from other non-pregnant causes. And unless you know the underlying pathophysiology, it will be difficult for you to give a targeted resuscitation. Just to simplify the cause of maternal cardiac arrest, there have been several acronyms. The BUCHAPs have been the standard, and 5H and 4Ts we all know. But we have at Fernandez Hospital classified as ABCDE, UPS, and even AHA guidelines ABCDEFG. But whatever it is, these are the common causes of maternal cardiac arrest: anaphylaxis, anesthetics, bleeds in the brain, bleeds in the liver, like intracranial hemorrhage is the commonest cause of maternal mortality in patients with uncontrolled or severe preeclampsia. Cardiac causes, drugs like magnesium and tocolytics. Fortunately, tocolytics are less used and safer tocolytics are being used now. But commonly, yes, magnesium sulfate, if you give rapid bolus, we have seen cardiac arrest. Eclampsia, embolism, amniotic fluid embolism, as Dr.B.Bande has just discussed, pulmonary embolism, uterine ruptures. U is for uterine rupture, ruptures, inversions, abruptions, again, relatively rare because of good antenatal care. And placental causes, yes, adherent placenta incidence is increasing predominantly because of the raising cesarean section rate. And of course, lung issues, which Dr. Allison has elaborated quite in detail. And of course, not to forget the sepsis, which has now become the leading cause. If you look at dissect the causes of maternal mortality, it is basically, again, lack of training. And if you look at the near-miss data, which is 1 in 141, almost 50% of this are the subset that have cardiac arrest. It's very, very important. And when you look at or analyze or introspect the cause of maternal mortality, it is mostly the knowledge deficits and the poor resuscitation skills that have come predominantly in most of the parturients who had unfavorable outcomes. Fortunately, we have a team, the obstetricians team, the anesthesiologist team, and the critical care team, which we take care of critical care unit also at Fernandez. We have a grilling protocol, and we conduct OELSS program, like obstetric anesthesia, obstetric emergency life support skills program, very regularly at our hospital. And we have a code blue team. With this, then our success rate of PMC is almost 58%, which is comparable to the international standard. What we already know in maternal cardiac arrest, yes, high quality CPR is what is important. Rapid migration from BLS to ACLS, ideally should be less than a minute. The mother has to be taken to ACLS algorithm, that is, intubation has to be done, definitive airway has to be managed, and very importantly, the left uterine tilt has to be maintained. And earlier we used to provide the wedge, but again, wedge is out of work now because we know that the intensity of chest compression reduces by almost about 37% when you keep 30 degrees tilt. So wedge, the person who provides or LUD also should be standing from the foot and side so that they don't interfere with the chest compression. It's a 2-hand technique or a 1-hand technique. And by these LUDs, you can effectively improve the cardiac output, because we know that when the mother is lying supine, the preload to the heart is reduced by almost 27 to 30%. And by using this LUD, you can almost improve the cardiac output and make the attempts of CPR quite successful. We also know that venous access has to be supradiaphragmatic, and we know that airway requirement, oxygen requirement is almost 300% more in term pregnant patient, and especially the laboring parturient is almost 500% more than a non-pregnant patient. So definite airway access like CAB and ABC has to go simultaneously as far as pregnancy is concerned. And instead of interrupting the chest compression to check the carotids, it is always better to rely on capnography to achieve ROSC, because by interrupting those momentary chest compressions for even 8 to 10 seconds, you may compromise the cerebral blood flow. So rely on ROSC. Our recommendations, in fact, the AHA also recommends that all defibrillators should have entitled carbon dioxide. And in our hospital also, the defibrillator, which is a biphasic defibrillator, has a EtCO2 monitoring. And we know that post ROSC, you need to appropriately adjust the ventilatory settings, because it's a period of apnea and hyperventilation. You may see momentary increase in carbon dioxide. and which may affect the, or if at all you're doing a fetal, perimortem cesarean section, you may end up with a fetal depressed neonates, which may require intubation. If you see the CTCO2 level invariably is high in a patient who achieves ROSC. And we know that if you cannot achieve ROSC, the maternal code 4 weeks, you start perimortem cesarean section, and 5 minutes is nothing but you need to deliver the baby. And first post-delivery, once the cesarean section is completed, patient is shifted to ICU for the resuscitation care with a targeted hypothermic management. So these are the things that we already know, and these are the standard guidelines that have been mentioned by several societies, including European societies, American Heart Association. But out of the experience of 12 perimortem cesarean deliveries at our hospital, and when we introspected these cases, we had great revelations, and that is what I want to share. I'll just briefly describe a few cases that reoriented ourselves to manage these cases. First one is a 28-year-old primary gravida, 34-week gestational age. She flew from Middle East in view of preeclampsia. She was a dual antihypertensive. At admission, normal preeclampsia profile was done. She was quite stable. CTGs were done that were reassuring, and we thought we should just give her steroids of fetal lung maturity, and there was no urgency to do cesarean section. And patient was serially monitored in the ward. On day 3 of admission, patient complained tightening in the tummy. She was shifted to high dependency unit, and she was having hypertensive crisis, for which labetalol was started. It was well controlled. We repeated the preeclampsia profile, and at this stage, anesthesiologist was involved because of our patient tightness in the little bit of tightness in the tummy, upper part of the tummy, and ABG revealed mild base deficit. We, as a protocol in all severe preeclampsias or hypertensive crisis, we do blood gas analysis in our hospital. And because of hypertensive crisis and the background, the obstetrician decided to do a category 2 cesarean section. She was already started on magnesium sulfate therapy. And spinal anesthetic was decided because platelets looked at okay, PA profile was normal, area also was fairly okay. Typically, this day 3 happened to be a Sunday, 9:30 a.m. Arrival to OT, the tightness in the tummy increased, reassured the patient, and standard monitors were connected, which are fairly stable vitals. SpO2 was around 96%. Little tachypneic, patient was little tachypneic, and patient was kept in sitting position while the anesthesiologist went to scrub to wash for the spinal. When she came back and painting the patient's back, the tightness in the chest increased, and she became little agitated, and she said she cannot sit. So spinal was abandoned. Patient was made to lie down. She was very uncomfortable, writhing on the OT table, unable to lie down flat. And immediately we looked at the monitor, the anesthetist, and she found that there was intense bradycardia and patient just was frothing out like acute pulmonary edema. She immediately called for help. It was a Sunday morning, one person on duty. Help was almost an hour away. But immediate CPR was done, patient was intubated, AC was on. And because it happened in the operation theater, obstetrician also was ready with the knife, and perimortem section was done. ROSC was achieved within 4 minutes, or rather immediately. As baby was out, and ROSC also was achieved. Patient was put on supports and relatively stable. Post-delivery, there was atonic PPH, which was controlled with oxytocin via syringe infusion, and IM corboprust also was given. Post delivery, again, patient had 2 episodes of brief cardiac arrest, almost about 30 seconds to 1 minute duration, which required 1 milligram boluses of adrenaline. And it was just basically a systolic type of pulses electrical activity was seen, shocking rhythm. But fortunately, both the episodes, 1 minute to 1.5 minutes, we could revive her. And by then the help also had arrived. Baby was kept in NICU, recovered well, not without much of a problem. Post-resuscitation, mother was shifted to critical care unit at our own hospital, the other hospital, which is about 1 kilometer away. And post-op workup, by and large, was normal. NT-proBNP was high expectedly because of pulmonary edema. Unfortunately, the mother ended up with a permanent vegetative state. So basically, despite achieving ROSC within 4 minutes, but patient subsequent 2 more episodes of brief cardiac arrest, she became like probably hypoxic injury was there, and she shifted to a rehab center. Ultimately, I think at 4 months later, the patient succumbed. Baby was fine. What we learned from this case, I'll come a little later. This was the second case, which was referred from infertility center. Basically, this patient was a 45-year-old lady, elderly primary gravida, 32 weeks pregnancy, multiple cycles of IVF, ICSI conceived, DCDA twins. She was admitted locally with breathlessness, and the physician there evaluated like heart disease complicating pregnancy. Basically, in view of breathlessness, she was having like the diagnosis MS with atrial fibrillation. She was given steroid cover, which was initiated there, transferred to our center in view of orthopnea. She was having PND, and with instruction, the obstetrician instructed the patient to be shifted to theater directly because of fetal compromise and ICSI conceived a precious pregnancy. At arrival to Fernandez, she was extremely diaphoretic, extremely tachycardic, tachypneic, like so dead space ventilation, breathing at the rate of 55 per minute, blood pressure not recordable, pulse oximeter not sensing the Massimo probe we have. And fortunately, we could obtain a femoral venous access. And if you look at severely metabolic acidosis, PaCO2 of 9, grossly hyperventilating, bicarb of 5, and base deficit of -27, and severe hypokalemia. With the background of MS with atrial fibrillation, we thought it was cardiogenic shock. We gave boluses of fluid, but quick bedside ultrasound revealed IVC was collapsed. It was not plethoric. So at least there was no problem in giving some fluid. So we gave about 500 ml of bolus, and we thought we'll just shift to theater and intubate her there. While shifting the patient to the theater, transferring the patient from the ICU bed to the OT table, she arrested. It was a VT. She was shocked, intubated, fluid were escalated, ACLS was on. Immediately, perimortem cesarean section was done. ROSC also was achieved. Again, post-delivery patient had etonic PPH. It was, we are there as a team, and we requested surgeon to apply compression suture. Cautious deuteronics were administered. Fortunately, both the mother and the twins recovered. And when we evaluated the patient post-operatively, it turned out to be diabetic ketoacidosis, which was undetected. There was no cardiac issue at all. So basically, it was a steroid-induced maternal hyperglycemia. And on questioning, discussion with the obstetrician, we also found that she was on ritodrine. That was started with certain preterm labor. So ritodrine combination with steroids, worsening of hyperglycemia, and the conventional oral OGTT that we do around 17 weeks and 26 weeks was not done. Only FPS, PLBS were done, and she was actually a diabetic lady. So a combination of steroids with tocolytics leading to SVT and brief, which was diagnosed as atrial fibrillation and was referred to as a wrong diagnosis with us. But fortunately, the patient survived. Babies also survived. Both were discharged on 6th POD. The baby and the mother were followed up for almost about 6 months. There were no deficits. Even the baby's cot pH was around 6.8. But fortunately, they recovered because it was diabetic ketoacidosis. The third case, again, was a case of severe preeclampsia, 30 weeks gestational, scheduled for emergency C-section outside. She had 4 episodes of seizure, aspiration. It was a documented cardiac arrest because the anesthetist there at the nursing home said patient arrested. He revived, resuscitated, and immediately, instead of doing the section there, they shifted the patient, which is nearby, to a hospital with the dopamine rate, infusion rate of almost 20 ml per hour, double strength dopamine, 400 milligrams of dopamine in 100 ml saline was given with an IV set because the patient was transferred from a small nursing home. At arrival, we shuffled the cardiac support. GCS was E1 M1 VT. She was not sedated, not paralyzed, post-cardiac arrest, but resuscitated. Pupils were mid-dilated. Clinically severe preeclampsia, aspiration we thought probably she must be having some intracranial pathology. We took her up for emergency cesarean section with a plan to do a radiology workup, MRI preferably, post-delivery, or at least a rapid CT scan if she is unstable. We gave an organ protective and neuroprotective anesthesia intraoperatively, and post-operatively, straight away we shifted the patient to the adjacent CT scan for brain, which was normal. And post-operatively, we gave targeted local hypothermia for about 24 hours. Organ supports were continued. Cardiac workup was normal. Next 22 hours, patient was extubated. It was an aspiration pneumonitis, which was resolving. And both subsequently, once the mother stabilized, we did a MRI, MRV brain, turned out to be a Press syndrome, no other pathology. And both the mother and baby discharged on the 7th post-op without much of a problem. This is the last case which I'm discussing. This was a maternal cardiac arrest and MRI suit. Patient was at 34 weeks, gestation age, obese parturient, hypothyroid, GDM on insulin. MRI was planned in view of diagnosis of placenta percutata on an ultrasound Doppler. Towards the last sequence of MRI, which 50 minutes later in the MRI suite, the radiologist saw there was SpO2 was not sensing, and it was showing as continuous alarm. So they called the anesthetist, and the anesthetist came and they realized that it was patient was almost patient had a cardiac arrest. Code blue was announced. However, because of they called the anesthetist little earlier, they could resuscitate the patient. ROAC was achieved, and patient was put on stiff support. MRI was abandoned, and it was indeed a percutata with invading the bladder. Just adjacent MRI suite was the emergency room. Patient was shifted there, and peripartum cesarean delivery, a classical section was done. Baby needed intubation but alive, but despite classical section, patient had massive hemorrhage, obstetric hemorrhage, totally exsanguinated. The surgeon could not control the bleeding despite manual aortic compression. Vascular onco team of the hospital were busy in the theater. By the time they came, it was total exsanguination that has happened. Massive transfusion was given, but it just happened just in few minutes. Patient was declared dead. Baby survived. Bereavement counseling was done. So this was the case, a similar case, but it was the adherent placenta. It was a live workshop. You can see Dr. Piley, one of the authority in adherent placenta at Thrissur. This was a workshop at Fernandez Hospital, morbidly adherent placenta live workshop. And you can see the large sinusoid in the lower segment. And he did a classical section. Patient was absolutely stable before delivery. But despite doing a classical section post-delivery, patient bled massively. The blood pressure dropped, almost arterial trace collapsed. It was a flat trace immediately. And fortunately, the vascular clamps were there with the surgeon in the set, and he put a clamp on the aorta, and we could see the difference, like BP. At least we could see the arterial trace immediately. And this is what happened. In less than 8 minutes, patient lost 12 liters. She was almost 22 kilos patient. So twice the blood volume she lost in just less than 8 minutes. But because it was an elective case, we were all prepared. We had blood in hand. This patient survived. So just to summarize the 5 cases, what we learned, lesson number learned, first we learned is approximately 70% of women who have perimortem cesarean section, they suffer atonic PPH. And rather than relying on oxytocin, we should go for judicious use of oxytocin and rely more on compression sutures. If you look at the first case, we could achieve ROSC, but patient arrested twice immediately despite ROSC being achieved. And subsequently, when we reviewed, oxytocin infusion was given, patient received carboprost, and the patient, again, 5 units per hour, in fact, my colleague gave almost 3 units IV bolus, which should not have been given post-ROSC. And subsequently, 5 units per hour also has resulted in myocardial depression, and mother sustained 1 more cardiac arrest. And we know that all this eutotonics, how dangerous they can be on the myocardium, especially a depressed myocardium, which has just been resuscitated. So atonic PPH are best managed with compression sutures and judicious use of oxytocin. Now that we have carbitocin, I don't know how safe is carbitocin. The only time will tell us. But yes, oxytocin is very dangerous in a depressed myocardium, especially when the ejection fractions are low, and you have to use very judiciously. And none of the guidelines, they emphasize on the usage of oxytocin following cardiac arrest, following ROSC. And this is what we learned. The lesson number 2 that we learned is, if I recall the textbook of Miller, which I read during my post-graduation, the commonest surgery that was performed worldwide was tonsillectomy. And now today, if you look at the same Miller's textbook, the commonest surgery performed worldwide is cesarean section. So with the increasing rate of cesarean section, the placenta accreta spectrum numbers are increasing. We used to do, when we joined Fernandez Hospital in 1997, about 2 or 3 cases of accretas and percutas per year. Now we are doing almost about 3 to 4 cases every month. So that is what the magnitude of placenta accreta spectrum currently is. And the way things are going, and the way we had this case, a placenta percutata or with invading the bladder, having maternal cardiac arrest, we need to include vascular clamps in the perimortem cesarean section delivery set, because not every nursing, most of the 70 to 80% of deliveries happen in nursing home and maternity hospital, where you don't have backup from vascular surgeons or oncosurgeons or urologists or general surgeons. So we need to have an obstetrician trained in applying vascular clamps to the descending aorta. Life is important, even if they are little above the renal arteries, doesn't matter. But occlusion of vascular clamps is a definite way to stop blood loss, especially if you have to do a perimortem cesarean section in a lady who bleeds massively because of adherent placenta, who requires PMCD. So the inclusion of vascular clamps in a PMCD set is what we recommend. And because manual compression, we know, may not be very effective. And yes, we need to have fire drills and training to learn this procedure, which is life-saving. And probably in big hospitals, corporate hospitals or government hospital, where you have multidisciplinary teams, include team oncology and vascular surgical team or general surgical member also in the code blue team, so that especially when there's an obstetric code blue, so that these things can be done effectively. Third thing that we learned from case third is the preeclampsia with status eclampticus that was referred from an outside hospital is organ protective anesthesia. See, many a times, like once you achieve ROSC, the surgeon or the surgery takes another 45 minutes to 1 hour to complete if it is a cesarean section. And if the patient requires cesarean hysterectomy, it takes about 1.5 to 2 hours. So 1.5 to 2 hours are very crucial. And most of our colleagues working in a peripheral setup may not know organ protective anesthesia, the lung protective strategies, the neuroprotective strategies, the cardiovascular protective strategies, the splanchnic blood flow maintenance. So organ protective anesthesia is what should start immediately post ROSC, rather than patient being shifted to ROS in ICU and then post resuscitation care. So the 20 minutes to 45 minutes to 2 hours of duration that is spent in OT, organ protection should start from there, like a cardiac anesthetist. So we need to start cardiac organ protection right in the OT or right at the time of cardiac, at the side of cardiac arrest post ROSC, in order to improve the maternal neurological outcome. Because we all know that this effective resuscitation becomes futile if the patient has permanent vegetative state or hypoxic injury. Yes, not to undermine what you should know your protocol, you should be familiar with the protocol, the resuscitating equipment which should be there in your hospital, you should be familiar with this, and regular fire drills. This is a very effective, cheap mannequin which can be done. I mean, it's available about 4,000 to 5,000 rupees, and you can practice perimortem cesarean delivery in this, and you can apply vascular clamps also. So this resuscitative hysterectomy training is essential for every surgeon, every obstetrician. These are the photographs of the patient whom I discussed in case 2 and case 3. And this is what we do, our drills, obstetric emergencies, life support skills workshop we do every 4 months in our hospital. These are 2 Shailajas, one in anesthesiologist, one in obstetrician, and we take them through different skills. Our in-house obstetrician and in-house anesthesia PGs and neonatal team also. And the proud father sharing his picture. So basically, what I mean to say is almost 58% of survival rate PMCD is pretty good, and this can happen only when you have in-house protocols. Importantly, you also need to have protocol for unfortunate parturient who has been revived but is brain dead. Because organ donation, they are the ideal patient for to donate the organs, and we need to see that you give effective resuscitation and preserve the organ function so that they can become a good organ donor. With this, I conclude my talk, and I'm available for questions. Thank you very much.
There's a question on for you. Any experience of COVID pregnant women requiring lung transplant, and if yes, what was the outcome?
So we have not had any pregnant patients that have had such severe end-stage lung disease that required lung transplant. We've had 2 pregnant patients that we've placed on VV ECMO that ultimately recovered. But our institution has done 3 lung transplants for COVID, but fortunately, no pregnant patients.
And what was your experience with severe COVID disease and pregnancy during the peak of the COVID epidemic?
Yeah, so we are sort of kind of in our second wave right now, it seems, of the COVID pandemic, and we're certainly seeing, to me, it seems like more severe disease. We are seeing patients that are certainly requiring ICU level care. And we have sort of erred on the side of prolonging the pregnancy if patients are presenting prior to 32 weeks. And we are utilizing everything that I sort of discussed in my talk with kind of treatment of ARDS. We're proning the patients, we're using neuromuscular blockade and steroids. And I would say the majority of our patients, if they ultimately need to be delivered while critically ill, are ending up with cesarean delivery.
Thank you so much. There's a question which I think any one of you can take. I believe, Doctor, it's for Ravi. Fulminant dengue in a primee who was not in labor around 36 weeks, but had a non-reassuring CTG. The obstetrician wanted to do a cesarean delivery. Do we allow her to take this up or let the fetus die?
Oh.
It's a tricky question.
This more sounds like a astrologer's question. We have had similar situations before, and you see, if you ask the mother is always, if she's conscious enough, she'll say, "Save my baby."
Mm-hmm.
And I think this is where we have to be very careful, because we usually will end up losing the mother, especially the way you put it, fulminant dengue, But of course, when we find that this woman has fulminant dengue and she's already had intracerebral bleed, etc., and we know that clinically her chances of surviving is going to be very slim, then the decision making is much easier. But if not, I think this has to be a decision that is not being made by you and you alone. I think you have to make a collective multidisciplinary approach and then make the right decision, because if you may actually end up losing both. I think that is the word of caution that I would give. I mean, there's no right or wrong answer, but it has to be a very well thought of, well discussed, get all the parties involved, including the partner. And in our Asian setting, maybe even the in-laws, so that, everything is done appropriately. Yeah. Very difficult to answer yes or no.
True. Especially in cultural setups of ours, I know it gets very tricky. Yeah.
Very, very tricky.
It's another question is to Dr. Bande. Do you have an experience of an amniotic fluid embolism requiring ECMO? We can't hear you. I think you'll have to take off your...
Oh, we've had one that I can recall. It was a patient with actually a placenta accretum spectrum that just rapidly decompensated intraoperatively, and we think it was likely from an amniotic fluid embolism that we placed on VV ECMO, which she recovered within a couple days, actually. I think it's a really interesting phenomenon because these patients do have right ventricular dysfunction. So the question about VA ECMO versus VV ECMO certainly comes into play, but in general, their cardiac function recovers very quickly. So you have to be very cautious with VA. And that's why we ultimately went on VV ECMO for her.
Allison, how would you manage anticoagulation while on VA ECMO in this amniotic fluid embolism, who have fulminant coagulopathy as well?
Yeah, sure. So, in that case, when we went on VV, we didn't heparinize. We also were certainly dealing with a great deal of bleeding from our hysterectomy. She was left open and packed. And then once her coagulopathy was corrected, we went back and closed. But we just did not do anticoagulation while on VV, which you can temporarily get away with for several days, just keeping close monitoring of the oxygenator and things like that. But more so with VV, you can get away with holding anticoagulation.
Thank you so much. Indeed, Dr. Sunil, I have one of my patients who really keeps haunting me a lot. And we had a patient similar to yours, as morbidly adherent placenta, came to a casualty, had a cardiac arrest on arrival. She was actually, there was some intervention done outside. And we kept on, resuscitating her. She would come back and with good support. And the whole ordeal went on for another 6 to 8 hours. And every time she would be a good fluid and, responded to blood products. And, but ultimately we did lose her out. And I just wanted to find out, if there are patients who kind of respond, how long do we continue with them? We really wanted to take her on an ECMO, but somehow the entire multidisciplinary team did not agree to, despite a definitive surgical intervention being done in her.
If you have a early airway control and oxygenation is ensured, then unlikely that they have poor neurological outcomes. So you have to be very, very aggressive. And majority of them, if you provide stiff organ support, first few hours or couple of days, most of them, they come out.
So I believe, should have we gone for an early ECMO support?
Yes, absolutely.
Yep.
Thank you. Since it's been an excellent session, enlightening as well as enriching to all of us, and we do not have any more questions. Do we have questions from the panel up here? So
have you tried any prone ventilation in term pregnancy, antepartum, Alice? ARDS.
Have we?
ARDS patient requiring like stiff lungs, poor PF ratios. Have you tried prone ventilation in term patients or more than 30 weeks of gestations, remote from pregnant term?
Yeah, we have. Certainly prior to intubation, a lot of these patients are doing self-proning, even if they're term. I would say, the majority of patients after 34 weeks, if their trajectory is not improving within 24 hours or 48 hours of presentation, we ultimately are delivering once they've completed steroids. So probably the most advanced gestational age that we've proned is, I would say, maybe 33, 34 weeks, but certainly with a gravid uterus. And we've had very good outcomes in terms of safety profile, and that, very minimal breakdown from pressure injury, safety in terms of we haven't had any accidental extubations, and we've been able to do continuous monitoring. We are uncertain about the effectiveness, though. We also are currently looking at the improvement in mechanical ventilation and improvement in P to F after proning, and hopefully we should be able to publish that shortly, but we're not seeing as much of a benefit as what we had hoped for.
Okay. Dr. Bande,
can I ask a question?
Yeah.
Can I ask a question, Sunil?
Yes, please.
Yeah. So, Allison, what is your policy regarding the termination of pregnancy? There's always a debate about this. So do you have any policy laid down, or it is left to a circumstances and decision of a team or something?
Just in terms of termination in pregnancy in general, outside of any specific
patient with poor, like stiff ARDS, poor oxygenation.
ARDS.
I see. So again, I think that's a multifaceted question in terms of the timing of presentation. There at our institution and at Maryland specifically, in the state of Maryland, there is no gestational age threshold at which you cannot do a termination. So I think if it was at a just peri-viable gestational age or even prior to viability, and the family wished that for maternal benefit, I think that would be something that goes through the ethics committee. We have not had a case like that where the family wished to terminate for maternal benefit prior to viability, but that's certainly something that would go through our ethics committee.